welcome you all to the meeting of the Culture and Inclusiveness Action Collaborative. The collaborative is a key part of the National Academy of Medicine's effort to foster health transformation, health system transformation that leads us to a health system which is more efficient, more effective, more equitable, and continuously learning. The Leadership Consortium has been operating for the last several years, focused and work in 4 domains: the digital domain, the evidence development domain, the financing domain, and the culture and inclusiveness domain. And the important thing to underscore is that the collaboratives that represent our work and carry forward our work in each of those domains are dependent upon the work in the culture and inclusiveness domain for their success. We are, as a society, in a fashion that has been brought home poignantly and in some respects painfully in the recent period, dependent upon our success in effecting a national focus and national accomplishment of efforts to reduce health inequities. The Achilles heel of our great society is the pervasive presence of inequities in a society which is the most wealthy society in the history of the world. So our work in culture and inclusiveness is fundamentally aimed at ensuring both that we are aware of the challenges before us and that we are positioned in a fashion to foster the changes that are necessary if we're going to ensure that the kind of progress that's possible for us as Americans is possible for every aspect of our society. So I want to thank, again, each of you. I know that you've tuned into this conversation because you are sure you are leading in fundamental ways the progress in your own settings, and I want to thank you for that work that you have in play in your daily lives and in your communities. I also want to thank our co-leads. I have the privilege of my colleagues in the National Academy of Medicine and I have the privilege of working with 3 wonderful co-chairs of this collaborative. They are Mary Naylor, Sandra Hernandez, and Bill Novelli. Sandra Hernandez, I want to offer a special welcome to. As the president of the California Healthcare Foundation, Sandra has long been involved in our work and has recently agreed to serve as co-chair of this collaborative along with Bill and Mary. And so thank you very much, Sandra, for joining us in this respect and for the leadership that you provide for all of us in the many activities that you have led for so long. We've got a very exciting agenda in store for us today. I won't go through it because I think I'll defer to our co-chairs to do that, but I do want to emphasize how exciting we are to be in a conversation that we think will help position us to make a difference over the longer term and over the nearer term. I just want to make one other quick comment about work we have underway that again is touched on quite directly by the work of this collaborative. I mentioned the 4 domains. What I didn't mention is that our leadership consortium, the National Academy of Medicine Leadership Consortium, is made up of leaders from 9 different sectors of health and health care. And those sectors range from the patient, family, and community sector, all the way through the health product manufacturer and innovator sector, to the health payer sector, and on to the quality, safety, and standard sector, with the other contributors that you might imagine. I won't go through all of them, but the point is that with that range of participation and leadership available to the National Academy of Medicine, we are taking advantage of our longstanding relationship with the sector leaders to sponsor a series of sector assessments. So we have senior representatives from all 9 sectors who are working together to look at each of the individual sectors to assess the extent to which the COVID-19 pandemic has underscored, again, in painful ways often, the fragilities in our system as a whole. The sharp relief of our systemic frailties has been clearly present and prominent in so many of the videos, for that matter, not to mention the reports of the challenges that we as a society have had in dealing with COVID-19. From the fact that the African American population has suffered 4 times the infection rates and the death rates as the rest of the population, from the fact that previously successful and stable healthcare institutions have now found themselves, on the one hand, burdened with overflowing emergency rooms, and on the other hand, empty wards because of the limitations on elective care and the economic challenges that go on with those circumstances, to the fact that we've seen our ability to marshal the public health response that we need limited, because not only because of the frayed nature of our public health infrastructure over the last few years, but also the result of lack of collaboration between agencies and organizations that have to collaborate in order to respond effectively, to the fact that the economic consequences of the pandemic have hit most painfully on our most vulnerable populations. So we have a great deal to learn from the lessons of COVID-19 for our health system, and we will by February, by fall, have a pretty good sense, at least at that point in time, of the kinds of broad systemic changes that are necessary in order to avoid these problems in the future, but more importantly, in order to move our whole nation to a transformed health and healthcare system that is bringing to the population care that is effective, efficient, equitable, and continuously improving. So we're looking forward to working with all of you on those counts as well. And the meeting today of the Culture and Inclusiveness Action Collaborative is going to be an important start for us all on this journey to a dramatically improved health system. So again, thanks to every one of our participants. Special thanks to Dr. Mary Naylor who is the director of the new Cortland Center for Transitions in Health at the University of Pennsylvania School of Nursing and co-chair of the collaborative, to Dr. Sandra Hernandez, who I mentioned is president and CEO of the California Healthcare Foundation and co-chair of the collaborative, and Bill Novelli, who's professor at the McDonough School of Business at Georgetown University, co-chair of the Coalition to Transform Advanced Care, CTAC, and also past CEO of the AARP. So thanks to each of you. And Mary, let me turn the floor over to you and your colleagues.
Thank you, Michael, for setting such an eloquent and important stage for this conversation today. On behalf of my co-chairs, Bill and Sandra, I am delighted to join Michael in extending a warm welcome to the more than 1,100 people, at least as of a few hours ago, who have joined us in the first public webinar sponsored by the Culture and Inclusiveness Action Collaborative. As reflected in our name and reinforced by Michael, this collaborative is designed to promote a culture that prioritizes access to and delivery of equitable healthcare for individuals, for families, and communities. At no time in our history has an intentional focus on equity and all of its inextricably linked dimensions, health, social, and ethical, been so critical. The collaborative seeks to advance an environment where policies and practices promote engagement of people in decisions about their health and ultimately positions all to have a fair and just opportunity to be healthy. We do so by engaging a broad range of key stakeholders, some of whom you'll hear from today, who have a deep understanding of the challenges contributing to inequities, and as a collaborative committed to action, work in small groups and as a collective to advance evidence-based solutions. A paper set to be released this Monday, upcoming Monday, July 13th, Patient and Family Engaged Care, an essential element of health equity, is just one example of the outcomes of this collaborative, and a link to this paper will be shared with all attendees when released. So let me share with you now a brief overview of today's important session. We'll begin the session hearing from leaders in patient engagement, exploring opportunities and challenges to equitable, meaningful engagement of patients and families in care settings throughout the pandemic. In the next session, we'll focus on specific strategies to address health equity at system and policy levels. The speakers throughout are sharing their experiences drawn from their work from health systems, state and federal policymaking and funding organizations. There'll be conversations following their brief presentation that will also reflect on the short and long-term opportunities to leverage the unique position of the Leadership Consortium, National Academy of Medicine more broadly, to scale and spread these approaches to systematically advance health equity. So now let me turn the session over to Bill, who's going to walk us through some logistics. So, Bill, are you there?
Are you on mute, Bill?
Okay, now I'm going to start over. Welcome, everybody. I'm glad you're with us today. Thank you, Mary. Michael, I want to thank you for your leadership. And now we're going to go over a series of presentations. And we're going to have the opportunity for some discussion during each session. So speakers, we ask that you turn your video on when you're speaking, and please keep yourself muted when you're not talking. We're going to start by calling on a few people, and if time permits, we're going to answer some questions submitted by the webinar participants. If you're watching, please type your questions into the Q&A function located at the controls at the bottom of your screen on the Zoom platform. And please include your name, your organization, and if applicable, who you are directing your question to. We're going to set aside time at the end of the webinar to address as many of those possible, although you may submit questions at any time during the presentations. And finally, a recording and copies of these presentations are going to be available to view after this event. So now let's go to the first session, patient and family engagement during COVID-19. This session is going to explore opportunities to engage patients and families in care settings during the pandemic. The discussion will focus on identifying solutions to the continued and existing gaps in engagement that are especially critical to address at this time. Our first speaker is Dr. Natasha Washington. She is the founder and the president and CEO of ATW Health Solutions, a management consulting and research firm based in Chicago, and she's a board member for the National Quality Forum. Dr. Washington is a thought leader, an advocate, a researcher, and a performance improvement expert. She's worked with healthcare systems and U.S. government agencies to ensure that patient-centered and equitable approaches are at the heart of healthcare redesign. And then we're going to hear from Beverly Johnson. She's the president and the CEO of the Institute for Patient and Family-Centered Care in Bethesda, Maryland. Bev has provided technical assistance for advancing the practice of patient and family-centered care and creating effective partnerships with patients and families to over 300 hospitals and health systems. Now, each of our two presenters will speak for 7 to 8 minutes. Please turn on your video when you're speaking, if at all possible. And our staff will be controlling the slide deck. So please remember to indicate when to advance to the next slide by saying next. And even online, we can't escape the timekeeper. We're going to have a feature where you'll be told when you have 1 minute remaining, and also when your time is up. And so first, Dr. Washington.
Thank you so much, Mike, Bill, Mary, for the opportunity to speak on today. If we could advance the slide a little bit. I've been professionally trained, educated as a healthcare professional, working more than 20 years, primarily as a consultant transforming healthcare. And there has not been a time more critical in my career that I've seen where our need to transform healthcare is really predicated upon a couple of major drivers, and that's both equity and engagement. If you can advance the slide, please. So the lens in which we see our healthcare system, and that lens in which we bring our ideas, innovation, et cetera, to transform the system is really through the lens in which we see the system. That is so critically important, and I say that because the lens in which I see our health system is the lens in losing my father to a preventable medical error, but being told that he had died of a heart attack. So I don't know if even, if here we are, 11 years later, if the issue for me really is trust in the healthcare system or the lack thereof, and I'm going to talk a little bit about that moving forward, or is it truly the pervasiveness of medical errors? Advance the slide, please. So, where are we in all of this? COVID-19, I think COVID-19 really opened up the eyes of many. But to be quite frank with you, for someone who's worked in this space for many years, seeing the disparate numbers come out as a result of COVID-19, in particular with the Black community, was not a surprise. As a matter of fact, for me personally, it was rather depressing to see, because for the first time, I think in a long time, it was an opportunity to really evaluate the fact that we have not made much progress at all. And to some degree, it even prompted, me being emotionally sunken to some degree, because I'm looking at the issue of a community in which I represent. And so here we are dealing with COVID, and then there is the issue or the death of George Floyd and his killing. And again, to be quite frank with you, I clearly understand, the voices and where we've been moving politically, but to be quite honest with you, it's the pandemic that I've been living my entire life. It's the pandemic that I've been living as a healthcare professional in an attempt to assert the fact that health equity has to be important in our work that we do to transform our healthcare system and to improve quality. If you can advance the slide, please. So I bring up the point of the 6 aims of healthcare merely to call out the fact that the equitable piece has been the least of those that we focused on. It has been noted as a priority decades, but yet we have continued to lack in asserting, moving a meaningful and a real agenda as it relates to that. One of the primary pieces of work that I have done over the years is to really integrate this concept of health equity into the work that we do in person and family engagement. And for me, which was, very simple to conclude, one patient isn't all patients. And so how do we create frameworks, or how do we create engagement strategies when we create agendas that are very vanilla and that do not really bring into context the beauty in all of the diversity that's represented in the patients in which we serve? I can go back to the case of my father and just pain management, and you can do the research for yourself when you think about pain management and how pain management is even dealt with at the bedside, in particular with Black patients in comparison to their white counterparts. And when I recall my father's case, then I think about how does a very vanilla and bland approach to patient engagement, how does that now address my uncle? How does that address my aunt? How does that address my neighbor? How does that really engage all patients? And so I think what we have to do is make certain that we get away from the notion that we can treat all patients the same, and that in order to activate patients, the same amount of energy and the same amount of resources can go into activating every patient and bring the result in which we want to see. Because the truth of the matter is that equitable means that we are pushing to ensure that all patients can get to their most improved outcome for themselves. Advance the slide, please. And so that's exactly what we see here when it comes to the definition that CMS put on the table around person and family engagement. And as you read to the very bottom where I've highlighted there, it talks about health equity. And so I think about the fact that, there has been a lot of work done to improve the patient voice in our hospitals and our health systems. Yet many of the patient and family advisory councils, so on and so forth, lack diversity and inclusion. So we really have to ask ourselves the question, why? Advance the slide, please. Well, much of it goes back to, what I've talked about a little bit earlier, and it's really about the infrastructure, the structural inequities, meaning the voices that have been at the table to really shape this agenda have not necessarily represented the diversity that we see in our American people. And I believe it is for that reason we actually need to very critically examine our patient engagement strategies, the theories, the concepts, and apply that equity lens to ensure that we are really representing all people. In other words, structural inequity is one of the ultimate reasons why you have not historically seen diverse voices or diverse representation at the table shaping what our patient engagement strategy looks like. And so that has been one of the primary reasons that I have chosen to stay into this work, because of the fact that we have lacked diversity at the very helm of who has dictated what patient engagement looks like, how we defined it, how we execute it, and how we measure it. Next slide, please. And so really this is about how we're going to go about responding. The stimulus is there. COVID, George Floyd. Now you have many organizations, institutions, even cities, legislations advancing this understanding that racism is a public health issue. And so what will be our response? Next slide. It's really predicated upon the choices that we make. To be honest with you, I could have filled this slide deck full of data that I've been sharing with organizations over the past 2 decades of my career. And yet we have moved very slowly and adopted almost in a minuscule way what needs to be done in order to truly advance equity in our health system. So this is really today about challenging, connecting your heart with your head, and what my colleagues will present later in order to make the right choices so that we have the correct response. Because the data isn't new, the information isn't new, and actually, quite frankly, the conclusions aren't new. It's just what are we going to do different as a result of what we're experiencing today. Next slide, please. And so I'm going to go through just a couple of the couple of choices that we should be making. Number one, being intentional. Tokenism, we cannot any longer substantiate. What do I mean by that? I'll give you a great example. When I was asked to create the board for Cook County Health System here, one of the first things I did was I used data to help guide who should be on that board. And as I looked at the population of patients that were being seen in the health system, it was clear the percentage of African American, the percentage of Hispanic, the percentage of Caucasian, so on and so forth. And as I went to make my recommendations for those board seats, I did that consistent with the patient population that that system has been seeing. So oftentimes what we do today is we pull in diversity at the end, and so I'm challenging you to use data and information. The other thing that I'll say in closing is being authentic about this, because unraveling the systemic issues that we have will not happen overnight. This is going to be the overhaul. We're talking about dismantling many of the things that are embedded in our infrastructure that to some degree most individuals are not even aware of that are discriminatory. And so for that reason, we have to be authentic. And then, like I said earlier, applying the equity lens really means an internal and an external strategy. And so I challenge all of the organizations that are represented today, don't just think about your engagement strategy as it relates to purely your patients, but also your engagement strategy as it relates to your employees, because those individuals are critically important to this. And so that internal and that external commitment to advancing engagement is going to be important. Do I turn it back over to you, Bill?
You do, Natasha. Thank you so much. And now let's hear from Bev Johnson. Bev?
Thank you, Bill, and thank you, Natasha. I've been asked to talk about partnering with patients and families in really planning responses to COVID, but within a health equity framework. And I want to urge folks on the webinar today, I hope that the Institute for Patient and Family Centered Care can be a resource to you as you expand your partnerships with diverse communities most affected by this pandemic. Next, please. In early March, we felt we needed to be in touch with health systems to see how they were responding to the pandemic. We knew that they were restricting family presence significantly, and this was an important public health strategy, but how they were doing it and how they were communicating about it was really important. We reached some leaders in health systems who said, we don't have time to work with patient and family advisors and leaders. We just have to get on with doing it. And we thought this is a real missed opportunity, that we need to hear from the community, particularly the diverse communities we serve, and what these and these informal conversations where we could facilitate problem solving in groups. We reached out, and we had published a paper in 2012 about SARS. And one of the lessons learned there was that rigid restriction of family presence without supporting the mental health needs for staff, clinicians, patients, and families, and even leaders making these change had long-term consequences. So we wanted to see some change, and we helped show people what partnerships could look like. Next, please. Questions to consider in the webinar and the informal conversations, which we couldn't possibly answer in that short period of time, probably like your webinar today. So we published frequently asked questions to respond to the field and give them the language of how they can partner with the diverse patients and families they serve in implementing and bringing about change in policies related to the COVID pandemic. Next, please. We were also very eager to track what was actually in change in family presence policies in all clinical areas, in maternity and pediatrics, in adult ICUs, in ambulatory care, all across health systems. But we also wanted to track how these systems were partnering with patients and families in implementing these changes and in thinking about the impact on practice. We knew that to be safe, there were going to be changes, but there are ways that you can be consistent and provide respectful, inclusive, equitable care. To date, we've had over 500 respondents, 24 different countries. The survey is going to close the end of July, so I hope everyone on the call will fill out for their hospital or health system, and that we are publishing the data every 2 weeks, just sharing it so people can learn from the data as we go. So pleased to partner with nurse researchers at UCSF and the University of Washington. Next, please. At Children's National, they have partnered with their patient advisors to really have an opportunity, several times a week even, to involve these voices that represent the diversity of the community in planning for COVID-19 and in recovery. So shaping the website signage and scripts that staff are using to communicate to families. One of the programs that they have modified is the wonderful Parent Navigator program that supports families caring for children with special health needs. The Parent Navigators were repositioned really to build on their role and to modify in a way that they helped families become Zoom enabled and to see the benefit of what a telehealth visit could do for their family and the kind of complexity of care they interact through Zoom. And of course, they were doing it in multiple languages as well. Next slide, please. I think that one of the good things that have come out of this horrific pandemic is the forcing us to relook at transforming ambulatory care and to take finally advantage of the technology to build supportive, respectful, inclusive telehealth programs. And Cambridge Health Alliance serves the gateway communities in Massachusetts, multiple languages. And they have partnered from the very beginning. They're committed to build their digital engagement committee response with their patient partners. And they recently had a town hall that introduced the a town hall that introduced telehealth to their physicians. And the patient partners were an integral part of that and helping them see what they were frightened about with COVID and to help them see how they responded with support for telehealth. They will be their partners from the beginning of this work. Next slide, please. Ann Jackson is a cancer survivor and an advisor at UChicago Medicine. And she just serves as an example of listening to individual patient advisors and their perceptions of our healthcare system. She noticed, because food had been an important part of her life and her family, that there were people coming for cancer treatment who were hungry, who didn't have access to nutritious food. So she partnered with the leadership of the Cancer Center to initiate a food pantry and help stock it. And then with COVID, she's worked and partnered with social workers and with community equity for people living with chronic conditions. A wonderful, inspiring story, and she has big plans for the future. Next slide, please. I think leadership in addressing the issues of health equity and for leadership commitment to building effective, meaningful partnerships with patients and families is essential. We have support from the Lucille Packard Foundation for Children's Health to do a national study on PFACs in children's hospitals. And in a series of interviews, we learned from Seattle Children's that the first month that the held a PFAC virtual meeting, the Emergency Operations Center met with the PFAC. And the lead found it so valuable that she has come each month since that time. So this is frontline for planning for COVID, having a regular interaction with the patient and family advisors. In South Carolina, they just moved into their new children's hospital in late February in 2020. And the administrator of the MUSC Children's Health and the chief medical officer asked to facilitate bi-weekly unstructured office hours with patient and family advisors. Didn't want an agenda, just wanted to have an opportunity to address issues that emerged just in time. And very successful. Again, that shows commitment of leadership. Next slide, please. So in the very beginning, we reached out to a colleague, Sonia Ballantyne, who is a patient research leader at the Chicago Health Disparity Center. We've worked with and learned from Sonia about how to build partnerships with a very diverse community. She's worked and trained 100 African-American patient leaders with serious mental illness to engage in research. But she knew in the COVID pandemic that there were real digital divide issues. They had limited minutes on their phones. Many more had lost jobs. They needed to have access to their payment on a very regular basis. And she knew that we needed to use plain language in how we communicated the public health messages of COVID planning. So she was an important person in shaping the work we were doing. Next, please. So again, I think leadership is so important for us to build a workforce that understands that COVID-19 may not be the most important thing in people's lives, that for vulnerable populations, and we learned this in our work with HIV and AIDS, that immigration status or lack of access to food or housing or cultural language barriers or living with substance use disorder all can be major barriers to access to healthcare and participating effectively. So we need to build a workforce, and we need leadership to understand this and to welcome these partnerships to build a knowledgeable, committed workforce. Next, please. And some of the gaps I hope we'll discuss further in the conversation is one of the communities most affected by COVID-19 were the long-term care communities. And they lack, again, back to committed leadership, committed, knowledgeable leadership of how to build and support effective partnerships with residents, patients, and families, and also how to build an infrastructure in long-term care communities, in nursing homes, assisted living, for these kind of safety and quality partnerships. Next slide, please. And so really to build on and recognize that we do need greater diversity among our patient and family advisors and leaders. We've worked with a wonderful young doctoral student and helped develop recruiting tools that would ensure that diverse individuals and families were recruited to this partnership work. And I do see some encouraging, it may sound strange, we are signed attendance rates. There is more vigorous conversations that people from the diverse populations that often didn't have time to travel to a meeting on site in the hospital are now able to participate and participate in a robust way. There's hope, but we have to be intentional in the work we do. Thank you very much. And I'll turn it back to you, Bill.
Bev, thank you very much. Thank you, Bev. Okay, now we're going to have invited participants make some brief remarks, some reflections on the speakers' presentations. These will be comments from a sector-wide perspective, but also from their own experiences. So each of these reactors is going to speak for just 2 to 3 minutes. And the first person speaking is Dr. Kathy Blake of the American Medical Association.
So Bill, thank you so much. And thank you also to our speakers. And having read the materials in advance, but now hearing both of the presenters, there's much to be learned and much to be stimulus for conversation. So some of the things that I heard, one is the importance of patient-centeredness, now more than ever. We've spent a long time working on this, trying to advance it, but I think that if there is any silver lining to be found in COVID-19, that with the deprivation that patients have experienced of being away from their families, we now focus on that more than ever. The second thing that I heard and have replayed in my mind over and over again is the importance of humility. And I heard Natasha say, this is the pandemic that I have been living my entire life. And I think that we have to, therefore, and it's true for the American Medical Association, it's true for many, many parts of America, acknowledge our past, not be paralyzed by our past, but to then say, what is it that we will commit to doing going forward? And I can't help but mention the Center for Health Equity, established about a year ago at the AMA, led by Dr. Aletha Maybank. And we are now in our organization applying the lens to everything that we do in terms of diversity, equity, and inclusion. And recognizing that within organizations, you first have to understand yourself, to then understand your gaps, to then be able to start to advance and move forward. I think we also, in addition to having humility about our past, I think we also have to have humility about what it is that we know and don't know. And as a physician, I will tell you that I know a lot about cardiovascular medicine. That's what I am trained to do. However, for the person in front of me, who I may be meeting for the first time, I don't know them as well as they know themselves. And I need to be humble about the fact that they or their family member, speaking on their behalf, will be able to share that information with me as long as they think that I will listen and act accordingly. So it is not just knowing what you know, it's knowing what you don't know. The other thing that I was encouraged about is this conversation that is beginning within the profession, but also across healthcare, about how challenging it can be to navigate these times, and that none of us should expect to do it alone. And I'm reminded of the comment that a system that depends constantly on heroes is destined to fail. And so if you start with that premise, you then have to say, in these challenging times, it really does take all of us. That if we depend upon a system of heroes, when it is a marathon, not a sprint, that we will not reach our desired outcome. And lastly, I would also comment about our reliance lately, and it was discussed, in fact, we're relying upon it now for this conversation, on digital technology. And I'm reminded of the disparities that we had in America back in the 1930s and the need for a rural electrification project. And I would posit that this pandemic, in addition to uncovering lots of disparities, has also shown that we have a major disparity in terms of access to broadband. And that if we're going to reach a more equitable and inclusive healthcare system and society, that we need to be investing in maybe what doesn't seem like healthcare infrastructure, but it really is. And that everyone should have access to care where they want it, when they want it, using the method of their choice. So thank you very much, and I look forward to the ongoing discussion.
Kathy, thank you very much. The next is Stephen Hoy, who is with PFCC Partners.
Yeah, thanks, Bill, Bev, and Dr. Washington. Great to hear from you guys, and terrific as always. I couldn't agree more with Natasha's first comments about being intentional about this. I think we used to look at, or about just a handful of years ago, we'd look at PFAC efforts and say, talk a bit about what Bev just demonstrated, looking at data about the communities in which those engagement structures are intended to represent. And more recently, I'm thinking, or believing that a race-neutral response may not be enough, and we need to be even more intentional about tackling some of the inequity dilemmas in the health system that are so intertwined with education and other domains. I think, excuse me, and in doing that, I've kind of now seen a real use for data and information and data transparency. You know, although race, age, and demographic information and data, you know, may be limited now as people are even less inclined to share, you know, it does have a powerful, I think, impact on highlighting those inequities. So to start efforts driven by data that is transparent, I think would really mobilize some of that, and even bring some of that information to those engagement structures we have in place. I shared a lot of the concerns when the pandemic first arose, in that how we're taking all these steps backwards in patient family-centered care, and shared Bev's fear that all this great work we've been doing for a while have, you know, been stalled by this somewhat militarized response to a novel virus. And I can't help but think, I haven't been around long, I'll preface with that, but it seems as though those plans were drawn up a little predated to our new understanding about engagement. And I really want to hear from even others in the group how we might use this moment in time where we're starting to reflect on, hey, how did we do? How did those plans go? And weave in patient-family engagement and community engagement to really learn how we tackled not just the virus, but those competing priorities that live in people, that are a part of people's lives. And, you know, can we, in this moment, when we're starting to look back and say, you know, how are those plans? What would we do better next time? How do we use and mobilize patient-family engagement to, you know, improve those plans for the future? Thank you.
Thank you very much. Thanks for those comments. And now Stacy Palmer with the Barrel Institute.
Hi there, and thank you so much for the opportunity to share reaction. I'll start with Dr. Washington. I just want to say that I love and truly appreciate the passion that you clearly have for this and for your efforts to drive improvements. I think I'm especially inspired by your work of integrating health equity into the conversation on patient and family-centered care. I think that is so, so important. And as you mentioned, how do we create strategies that acknowledge the beauty of diversity in those we serve and get away from that notion that we can treat all patients the same? You also address the lack of speed to respond to needs in our current healthcare climate. And I think that that's been one of the biggest ahas from our community at the Barrel Institute during the current COVID crisis. It's been the ability of their organizations to move swiftly. They've been able to see policies updated. They've been able to implement telehealth in a matter of days or weeks. And other services that had been on the drawing board for years, all of a sudden we were able to make things happen. So one challenge I believe is how do we keep that momentum going and be able to address the important things with that type of speed. And I always love hearing from my friend Bev, and I love the work of IPFCC. I want to reiterate her comment about our need to hear from the communities that we serve. I think that's more important now than ever that we're enlisting patient and family advisors, and we are finding from our community that they're finding more and more ways to do that virtually, to do it in a safe way, but still requesting and asking for that feedback. And of course, the visitation concerns have been huge for our patient experience community. It's a group that's been really long advocating for care partner presence. So how do we balance that with unique needs within our organizations during this pandemic? So Bev, I just applaud you and your team for exploring best practices and sharing these stories so that others can learn. And I couldn't agree more on the needs and opportunities to better support long-term care and look forward to seeing more efforts in that area. Thank you for the opportunity.
Thank you very much. Dr. Tamara Cadet with Simmons University.
Hi there, how are you? Thank you all for this opportunity. Thank you both to the presenters. This stuff is sort of near and dear to my heart. Just a couple of points I wanted to make in reaction. I agree with sort of both panelists. This is nothing new. It's not a surprise where we are. And yet I'm still struck by the fact that it requires work. It requires a lot of work. It's not going to be easy. But I do think that we're in a position where we can step up. In some ways, I guess I've been thinking about all the change that's been happening as a result of George Floyd and all these other things. Can we take that energy? Can we take the data that we know? And can we build sort of our protest in some ways to begin to think about engaging patients and families in a better way? I think that, you know, when we think about engagement strategies, I think everything that we've heard has been so fabulous. I want us to sort of think about the fact that there's diversity within these diverse communities that we keep talking about. So, you know, we can't just say, and I don't think that anybody meant to sort of to do that, but I want us to recognize that when we're talking about sort of an African-American population, recognize the diversity in there. When we're talking about a Hispanic population, recognize the diversity in there. And as we're collaborating, just as Bev has talked about in her work, as we're collaborating with those social service organizations, recognize that it may be more than one because they're serving different types of populations, even though racially and ethnically they might be the same. I do think I so agree with that idea. If you know one patient, you know one patient. Every patient is unique. In my world and social work, as a social work faculty and researcher, we teach about listening. Patients and families are the experts in their lives. We may be the experts in the professionals, but they're the experts of their lives. So how do we truly listen and actually get them to figure out how they want to engage? Can we ask them, have we ever had a conversation around what engagement strategies should we be using? How do we consider teaching them and getting information from them about how to engage in a way that we do? And I'm doing some of that work and some of the research that I do. And then finally, I think just sort of as we're doing this, someone mentioned this idea of plain language and really recognizing that we all talk with these professional lenses and that literacy is huge. It's huge amongst the entire population. And there are risk factors related to age and race and socioeconomic status. But I do think that, some of the most recent research says that, much of the US population in particular, we're all at adequate health literacy levels. We're not all proficient. We're all at adequate in some way, shape, or form. And so really being conscious of that as we are starting to sort of develop these strategies. But all in all, how do we take those folks that we care so much about and truly engage them about what it means to have an engagement strategy? Because if we can get them on board, then they're going to talk to their neighbors and they're going to talk to their other community members about what works and be able to help us so that it truly is happening in a collaborative way versus us telling them or us inviting them. How about they invite us? So those are my quick thoughts. Thanks so much.
Thank you so much. Our last reactor is Laura Buckley, the Camden Coalition of Healthcare Providers. Laura?
Hi, everyone. Thank you for having me. I really agree very much so with the last reactor too, as I was taking down notes, that health literacy is also very much a part of this health equity conversation. But really reflecting on Dr. Washington's comments, and thank you so much for them. I really hear and appreciate your comments around our structural inequities in our healthcare system, and particularly in leadership, and how often those folks are the people who help decide what patient engagement looks like. Oftentimes for folks who don't look like them and have different experiences. And in thinking about equity, we often look at racial disparities, understandably, to highlight those structural issues that we're facing. And reflecting about your comment that racism is in fact a public health issue. We here in Camden, where I work at a community-based nonprofit, have been thinking a lot about reframing health issues that have racial disparities, to not think of it around a race issue, but really around a racism issue. And that this concept of structural inequity could also perhaps be reframed as like a medical apartheid. And I would love to hear more about like your thoughts or comments on that, and then what some of the other reactors have said to get more explicit around the impact of our direct patient engagement if we change those framings. Like how would our strategy shift if we think of it from not a racial disparity, but a racism issue? And then I also really appreciate Beverly's comments around her ideas of to support workforce mental health and committing to that knowledge base and decreasing stigma, because I think right now everyone is living through so much trauma, like acute trauma, structural trauma, generational trauma, and I think we have a long way to go to support our workforce and to support the patients that we're serving. So I really just appreciate calling that out. We also talk about that a lot in Camden. And thank you for having me. And thanks for your time.
Thanks very much. There's a lot of food for thought in what you just said. We received quite a number of questions, but we're virtually out of time. One of the big questions, which we could probably spend another hour on, is the need for better data. How are we going about utilizing data to improve the experiences as well as outcomes? But rather than dwell on that, which is a pretty complicated question, I'm just going to turn to one very personal note. And this is from Desiree Collins Bradley. She's a patient partner innovation community person. And she wrote this to Dr. Washington. She said, when you spoke on the trust and tokenism, it resonated with me. As a Black female patient partner, oftentimes I'm the only person of color at the table. How can a system make it clear that equity is a priority? Natasha, do you want to comment on that?
So I have to unmute myself. I apologize, Bill. Can you hear me okay?
We can.
Yes, awesome. Yeah, I really appreciate Desiree's commentary, and I'll just say this. It really requires some systems thinking. So this equity issue, if we're really going to get at a resolve, we have to take a systems approach to doing it. And that's in part to what I meant by being intentional and the authenticity of the work. This is not a fad, meaning what we're dealing with COVID-19, what we're dealing with just the levels of racism and just social unrest in our country. This is not just a time frame where we're going to respond to equity and then we go back to doing what we were doing before. Organizations that I've been working with in terms of helping them to develop their strategies, I upfront ask their intentionality behind this, and I do vetting of their authenticity to it, because if you're not willing to look at your approach from soup to nuts, from beginning to very end. And I'll give you this as an example, I guess better answered as an example, Bill. At an organization that I'm doing some coaching on developing an equity strategy within their quality improvement. And the statement was made, well, I asked about diversity in their leadership. There is none, and that's quite popular, by the way, in healthcare. I'll just leave that there. When I asked the question about who will lead this agenda, right? So you can't take an agenda. You can't go and ask a whole bunch of Black folks or Hispanic folks or Asian Americans to come to the table and help you develop an agenda, and then you attempt to carry it forth, right? That intentionality and that authenticity means that you're going to take a systems approach, which means that we're going to shake it up. And that's what leaders do. That's what leaders do. Leaders make very hard decisions, and they make hard decisions in critical times like today. And I think, to Desiree's point, if we're really going to get at, moving that needle, two things. One, it's a systems approach, and that requires both a push and a pull strategy. The way in which you do that is the organization takes responsibilities and does what it needs to do, but also as an individual, and I'll use myself as an individual over the most recent couple decades in this work, is that I'm always pulling someone else through. So Desiree's not new to me, as is the other, folks that look like me that might be listening on today's call, because one singular individual can't do it, and this is not about me. This is about my granddaughter. This is about my future grandchildren. So I hope that answers the question, but it's a systems approach in summary.
Thank you very much. In order to stay on time, we're going to go on to the next session, but please continue to ask your questions. And we've got some time at the end of the webinar to address more audience questions. And we will online get to them all. This was a really good session, I think, from top to bottom. And I think that what Natasha just said at the very end there might be our rallying cry. This is not a fad. And now over to Mary Naylor to introduce the next session.
Thanks, Bill. What an outstanding beginning to this webinar. And Natasha, you just provided an excellent segue to the next session, where I'm pleased to introduce the panel who will present on challenges and action steps needed to advance and spread system and policy level health equity strategies. The panelists have been asked to consider well-known flaws, at least well-known by scientists, health system leaders, clinicians in health and social systems, which COVID-19 has, as Mike McGinnis said, painfully brought to the public's attention, as exemplified by a front page story this past Sunday in the New York Times. Panelists have also been asked to reflect on wholesale change, not just tweaks around the margins that will be required both in the short and longer term to address, as Natasha described, intentional and authentic system transformation. So now it is my pleasure to introduce our panelists. First, we'll hear from Dr. Consuelo Wilkins, Executive Director, Meharry Vanderbilt Alliance, and Vice President for Health Equity at Vanderbilt University Medical Center. Dr. Wilkins is widely recognized for her work in stakeholder engagement and is principal investigator of a PCORI Research Award focused on improving patient engagement and understanding its impact on research. She will be followed by Dr. Takesha Everett, Executive Director at Health Equity Solutions. Dr. Everett served as the Managing Director of Federal Government Affairs with the American Diabetes Association, where she provided strategic leadership on policy and advocacy initiatives with the White House and several federal agencies. And lastly, we'll hear from Dr. Kara James, President and CEO, Grantmakers in Health. Prior to joining Grantmakers in Health, Dr. James served as Director of the Office of Minority Health at the Centers for Medicare and Medicaid Services, where she provided leadership, vision, and direction to advance the U.S. Department of Health and Human Services and CMS's goals related to reducing disparities and achieving health equity for vulnerable populations. Each of these presenters will speak for about 10 minutes, and just a reminder to each of them to unmute your line when it's time when it's your turn to present. So now, Dr. Wilkins.
Thank you so much, Mary, for the opportunity today, and thanks to Michael and Bill and others. It's my pleasure to share a little bit today about our approach to health equity at Vanderbilt, and really thinking about the questions that we're being asked is important, because our approach here is to think about health equity at a systems level. So I'll start with my first slide. I believe is just a title slide there. Really, though, the goal is to make sure that we have health equity at the leadership level across the medical center. So I'll share a little bit about that. Next slide. So our Office of Health Equity at Vanderbilt was created at the beginning of 2019, when we, after several years, began to try and identify the best next steps forward. We had lots of opportunities to build on work in research and community engagement, as well as expand our focus in education, and eventually decided that we wanted to take a different approach and have a more centralized structure that's the purpose, the intent was actually to foster and catalyze health equity work across the enterprise. So our community health needs assessment is a part of our Office of Health Equity, and I think that's really important as we think about what priorities we're responding to and how we actually organize as an institution. And then we have work that's really falling into those traditional academic missions of clinical enterprise, research, and education. And so we have work that's spanning all of those areas. But and really important for me in taking a leadership role in this office was to make sure that there was some institutional and leadership buy-in. And so having actual metrics that are tied to incentives and at the leadership level is part of what's also baked into our office. I do want to make the distinction between health equity and diversity, equity, and inclusion. So we have a really robust Office of Diversity and Inclusion that's led by my colleague, Dr. Andre Churchwell. And we thought it was very important to actually distinguish our work in health equity, which is truly focused on making sure that everyone has the best possible opportunity to be healthy, looking at health outcomes. That doesn't mean certainly that we don't care about the diversity of the workforce or that we have an inclusive culture at VUMC, but that's not my primary goal. My goal is actually to focus on health outcomes, making sure that we are actually removing barriers, thinking about those social domains of health, and how we actually prepare the enterprise to address those. So next slide. One example of that is that in the last year, we've created this certificate in health equity for our medical students. And this requires that the students actually have foundations in health equity where they learn about power, privilege, race, racism, the structural competencies that really drive some of the health inequities that we see. In our course, that's the first Foundations of Health Equity, there are 3 full days of this only 2-week course that are dedicated to dismantling racism and addressing white supremacy. So these are things that we've been working on and need so much right now, and are trying to determine how to best actually scale those to others who are realizing how important they are. Next slide. So as it relates to COVID-19, when our COVID-19 Command Center was put together at Vanderbilt, like so many across the country, there was a focus on epidemiology and ICU beds and PPE and ventilators and all of those things. And initially, we did not have a clear focus on health equity. But a couple of weeks in, our CEO and our deputy CEO, Jeff Balzer and Wright Penson, asked me to join the COVID-19 Command Center to really make sure that we were integrating health equity into all of that work. And so this slide actually shows those areas that we decided to focus on as part of our Command Center that are specific to health equity. So we, and not just me, so I put together a team of physicians, nurses, social workers, folks in the business space and operations and research, in different sectors of the medical center, to come together to try and decide what was the most important for us to actually do to prevent as well as address health inequities related to COVID-19. So we came up with 5 areas to focus on. Effectively communicating risk about COVID-19. And I want to emphasize here that that wasn't just for our patients, but also for our employees. Recognizing that some of our employees, especially those for whom their job title or their roles aren't actually direct patient care, but they're essential to the operations of the medical center. So those who are responsible for environmental services, maintenance, dietary services, these are individuals who are at the hospital every day, but don't necessarily identify as a healthcare worker. And we wanted to make sure that the communications that were being created for them about how to don and doff their PPE, what to do with their clothes when they got home, took into account that not everyone had a garage that they pulled into and could take off their clothes and put them in a bag, or had a washing machine at home so they could actually place these and wash them every day. So we wanted to make sure that we weren't leaving out our own employees, because we see them as actually our first community. We wanted to make sure that there was equity in testing and surveillance, and that meant connecting with the public health systems, but also community partners, and looking specifically at how we're providing care. Are there differences in how we provide care based on race, ethnicity, social income status, or payer status? And down at the bottom, tiny is research, but not because it's not important, especially for a condition for which there's no proven effective treatment, but it's small here because there's another large stream of work focused on research. We also did focus on telehealth, and that acknowledges that not only are there known barriers to adoption of telehealth for some communities, but these are likely to be exacerbated during this pandemic. So next slide. So the first thing that we needed to do is to disaggregate the data that we had. And so having access to all of the people who are making decisions. So in the command center, all of the presidents of the hospitals and the chief nursing officers and the chief communication officer, everybody is there. And so one of the great things about this was being able to actually get things done quickly. So I asked for dashboards to be created so that we could disaggregate the data by race, ethnicity, and language. And what you're seeing on this slide is the data for language. So of our first about 46,000 people who've been tested for the novel coronavirus at Vanderbilt, 48 different languages were spoken other than English. And for those in that group of people for whom English isn't their primary language, they represented about 5% of people who were tested. But in that group, 26% positivity rate, about 20% of the total cases. So we early on saw some disparities among these individuals for whom they had limited English proficiency. And next slide. The other thing that we did in addition to looking at race, ethnicity, and language was we looked at zip code. And so we wanted to try and understand, what's happening in the community. And we identified that for the 2 zip codes that had the highest percentages of cases, the highest number of cases, they actually were 2 adjacent zip codes in the southeast part of Nashville and communities that were known to have higher percentages of refugee and immigrant populations. And understanding, not just what we could do as a health center, but how we needed to connect with community health centers in those areas, community organizations who are serving those communities, who are primarily creating and developing information in multiple languages. And so that actually led to not only making sure that we had information in multiple languages available within VUMC, but that we were supporting community organizations who were communicating in Arabic and Nepali and Spanish. As was mentioned earlier, it's important in this setting to also make sure that we are not thinking that we're the ones who have the most expertise. So we actually partnered with community organizations to have them actually lead the way in doing live streams on Facebook in Arabic and Spanish, and leveraging community organizations, faith-based communities to do this work. So these are some of the things that we've been able to do because we actually have this enterprise-wide focus and have resources that were already dedicated to health equity that we could then pivot to address this work. And then next slide. So that's an example of what we've been doing over the last few months as it relates to COVID-19. And as we've been seeing this increased focus and heightened awareness of racial inequities, we've also pivoted to make sure that we can provide more anti-racism resources and tools so that our staff and teams can actually respond as needed. We've hosted a series of panels focused on race, racism, and healthcare, and making sure that we can actually address those needs. And then tomorrow we'll actually be releasing the initial steps for VUMC as we begin a more systematic approach to confronting racial inequities, which will include developing a task force that will gather data and develop a set of recommendations for our CEO and our board, and anti-racism training for all of our C-suite leaders, as well as our board, and additional resources to make sure that we're embedding racism, anti-racism into our medical education and curriculum, and also building the tools to remove things from our curricula, as well as our operations, including also starting tomorrow, Vanderbilt will no longer report the race-based GFR, so the estimation of glomerular filtration rate. So we're really excited about leveraging this systems-wide approach and looking to learn from others.
Thank you, Consuela, for sharing what is amazing work going on at the Center for Health Equity at Vanderbilt. Now let me turn to Takesha for her presentation.
Let me adjust that camera a little bit. Thank you so much and good afternoon. I'm going to just pause for 1 second to get so that my slides come up.
Yes.
Thank you so much. So you can go to the next slide. We know that I'm here to talk about system and policy level strategies, and I'm going to start off with a bit of storytelling, which is the way I try to address and talk to people about these very difficult and challenging issues. So I work at a nonprofit called Health Equity Solutions, and our vision and mission is right in our name. Our daily activities are centered around advancing health equity, but specifically at the policy and system level. So our work is centered on promoting policies, programs, and practices that will result and equitable health care, access, delivery, and health outcomes for all people in Connecticut. And in doing that, we are unapologetically race forward, which means we focus very much on individuals who are considered people of color, which for us is inclusive of our Arab American, Muslim American, and Northern African individuals who are often considered, or who are by definition considered by the CDC as white. The reason I want to start spending a little bit more time on this slide before I go on is to highlight very quickly for everyone that this, years ago, I would come into this conversation introducing myself as an individual who is focused on health policy and has built a career there and chosen the lens of race. What I've realized in the 5 years that I've been running this organization is the reality is that I'm a race scholar who has chosen the avenue of health care and health policy as the way to effectuate change, because if we don't have our health, we have no ability to live we have no ability to reach and live our full potential if we don't have healthy lives. Additionally, my last point on this slide before I move on is that this is a personal, professional, and passion for me. I have lost both of my parents to avoidable situations that did not have to happen way younger than they should have. And this is the case that I could say for a number of people who are in my family. So at a very young age, I realized that there's something fundamentally unjust and problematic about the way we deliver care in our country and the process by which we do that. So this leads me to really being very clear about health equity. Next slide. So often our discussions around advancing health equity center around doing a lot around the social determinants of health, which in the last decade has become a very sexy term. One, I'm pretty certain that everyone on this call knows what it is, so I'm not going to take time to define it. But we've spent a lot of time in focusing on that. And literally what we've been thinking about is the fact, or where the conversation is going, is recognizing that health doesn't just exist within the four walls of care, whether we're in a hospital or a provider's office, and that we're trying to get the health system to understand or leverage its power and position to really impact what's happening outside of the healthcare system in efforts to bring people to their best health options. What is missing when we only talk about the social determinants of health and talking about equity, or think of it simply as solving or resolving SDOH, is that we're missing that by design, the healthcare system fosters inequity. If we start historically and look at the evolution of the healthcare system, how we've provided medicine for certain populations over others, the evolution of hospitals and clinics in our society, the fundamental premise is that it's all built on inequity. So what you're going to hear from me is a consistent theme that we have to and must, if we want to build equity, confront structural racism. And I'll talk a little bit about that in a moment, but I'm just going to say that again. If we really want to get to the point of equity, we must confront and dismantle structural racism. So while our current focus when we talk about health equity has been around the social determinants of health as a way to link to better healthcare outcomes, it's totally fine, and I agree with that, but it's only one side of the equation. We have to do more. We need to really be in tune and having conversations that are centered on understanding the historical disadvantages that have existed in our healthcare system, the historical disadvantages around the power imbalance that happens in our healthcare system. We have to really understand where these gaps what the gaps are in terms of seeing and understanding the disparities, but really beyond that, understanding the roots of them and where they came from. So I'm going to go to the next slide. To do this, I'm going to go through a few things very quickly, and recognizing time, because I, for one, really appreciate when there is a question and answer period in a webinar. So I'm really going to talk a little bit faster than I usually would, and invite you, if I gloss over something too quickly, or if I say something too quickly, to put a question in the Q&A so that we can address that. But what this slide is showing is kind of on the left side, I'm going to go through 5 key ways that at a state level we can address priorities around priorities for equity. And then what you'll see on each slide, and I'll come back to the end is how this aligns with the National Academy of Medicine's primary goals for health equity. So it's an opportunity to see that while you're not a body, and many of the people who are listening may not be individuals who actively engage in the level of state policymaking, you can see how you can have key ways and key individual priorities and goals within yourself that you can mirror and use at your own level. So we like to talk about at Health Equity, we like to talk about systems change where you sit and how you can engage this. And this is what this attempt is to do. As I work through this, I realized something I didn't say at the beginning. I want to take a moment and acknowledge the incredible staff at Health Equity Solutions who were very helpful in putting this together. A special shout out to Dashni, who I believe is also listening today. So instead of going over the slide, I'm going to go to the next one, and each one of these I'm going into a little bit deeper. So the first one is institutionalizing inclusion. And just as a reminder, I'm going through 5 key steps we can take today that help us in the pathway towards equity. Institutionalizing inclusion and embedding an equity lens. So one of the things that I've heard a lot of the speakers who've spoken so far, and have been hearing a lot lately, particularly given the environment we're in, is that we need to make sure we have diverse representation. And I think diverse representation only takes us so far if we don't have an institutionalized way of including individuals who do not reflect our own positions, our own backgrounds, our own culture into the organization or into the process of the care that we're delivering or into the work that we do. So in addition to having those people, what has to happen is a fundamental way of doing the work that focuses on embedding an equity lens. It's asking some critical questions, no matter what we're trying to achieve, about how what we're doing impacts and or influences health equity or and equity in general, particularly racial equity. So what we're saying here is that you need to have somebody in advertising, they kind of call it a traffic cop, somebody who's looking at all of the pieces and where they're going. In this particular instance, it mirrors it in saying you're looking for somebody or a group of people who are looking at equity in everything you do, who's taking a moment to think, if you change the hours in which you are open and deliver care, are you doing the best thing for the patients, and how is that impacting equity? If you're producing research and you are actually involving individuals in that research, what have you done to make sure that you have the most representative policies, the representative population as possible to reflect the people you are trying to address in the long term? So again, there's this person or people who are consistently, by routine, stopping the process and asking the equity question. Next slide. As I said in the beginning, and I'm going to say it here again, confronting racism is a super important thing. And the first point in this is we have to start by naming it. I think one of the reactors to the earlier panelists made this key point about saying we talk about racial disparities and we talk about race, but we somehow divorce that conversation from the fundamental fact of looking at institutional, interpersonal, and individual race, and internalized racism. What is very important here is that we need to recognize that in order, our diversity and inclusion efforts haven't gotten as far as we would like them to go, because we're fundamentally putting a quote unquote solution to a symptom without this really addressing the disease. And so when we opened this, there was a conversation about saying we want to go deeper than tinkering around the edges. I'm going to say that this is probably the one thing that I'm offering of the 5 that doesn't tinker around the edges. It requires us to imagine how we fundamentally reform and deliver care and change our medical foundations in our society in a way that we've never seen before. So I'm going to pause for a second and say that again, that we've never seen before. None of us on this call have ever seen a state of equity. We've never seen a country or a place that did not exist or have within it some bias related to race. We don't know what that looks like. In the US, it's always been our foundation. So what we're fundamentally saying is in order to create and dismantle racism and create health equity, we have to be acting towards a world we've never seen before. But that shouldn't scare us, because we can definitely use things like health disparity gaps decreasing. We can use things like looking at our internal institutional policies as well as our legislative and administrative state policies, how they have changed and what the impact are going, to really understand if we are moving towards that world we're hoping to see. One of the activities that we are actively engaged in right now in Connecticut is getting every city and town in Connecticut to declare racism a public health crisis or emergency. That'll mean something different at any level, but it's acknowledging the fundamental impact that racism is having on our public health structure. It is acknowledging how the fundamental impact that racism is having on the individuals for whom public health is designed to serve. The next part to this is to ensure that even within the way that we are looking at reforming our health system, the research that we provide, even in the convenings we are having, like today, it's making a point to pause and intentionally say, we acknowledge that structural racism impacts everything we do. The moment of just making that statement changes the fundamental function of what we are next doing. It acknowledges the power and difference, it acknowledges the problem, and then it forces us to really do something in action to it. I know what I'm saying right now is a really big concept, and I'm spending a lot of time on this one because it is the most important one. It is something that we created in our country, in our society, in our world, and it is something we have the power to dismantle. When I say we, I mean we as humans. I don't mean us on this call or this Zoom together, but we as humans created this construct. We can dismantle it. Next slide. So now, what does it mean to say that it is important to look at disparities as an indicator of whether we are advancing towards health equity and whether we are in fact dismantling racism? It's really saying we do need data. Data is important and critical. We have to be looking at data in a way that clearly shows us who and where we have the problem. If you haven't ever heard of the idea of targeted universalism, I encourage you to read about targeted universalism and read the work of John Powell, because this point about letting the data lead you to solutions that focus really squarely on the people who need or are most disadvantaged in the process of whatever you're doing is really critical here. What I'm going to point out on this slide is this image on the right. I think everybody may understand the concept of granular collecting better data, the need to utilize the data and put into action. I think Dr. Consuelo Wilkins made that very clear in her presentation. So I'm just going to focus on this image on the right, because it should astonish everyone who's on this call and who sees this, and who will also watch this later. The beginning part of this shows that when COVID first started and we started to release data, everyone started to really do these maps, and this is from Johns Hopkins, do these maps and start looking at who and how is data along racial and ethnic lines being collected. This top image shows you that there are only 4 states, as of 6 days ago, only 4 states who are reporting out testing by race and ethnicity. So what that means is we have no real idea who and how the gaps in testing are showing up, except for in 4 states around the lines of racial and ethnic populations. We have no clue unless you live in Nevada, Kansas, Illinois, or Delaware, I think. Can't even see which one that 4th one is. It could be DC, but I can't tell. And when we look at the deaths data, we have way more information around the fact that there is more data that is being collected on a race and ethnicity level across these states when it comes to death. So this is a huge gap that we should be looking at here and noticing. We can tell you who's died by racial and ethnic lines, but we can't really tell you our testing strategy and how that's working on racial and ethnic lines. So this is a really key relational thing here about this whole point is better data, collecting it, understanding it, and utilizing it to impact how we next act is really, 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 really critical. This is what can lead to the real change in how we act and what we do to help dismantle racism and to encourage health equity. Now, the one point I want to make on this solidly is this is the one place where I'm going to pause for a second and call out NAM's principles around health equity and how this could have really been avoided. This point about engaging and strengthening community capacity. If anyone had engaged the community about asking what was necessary or needed pieces of information, this would have been one of the first things they would have highlighted. We need to understand race, gender, location, zip code, all of these things. We need to be analyzing how we're doing our testing structures and how we're instituting our testing across there. That would have been something someone said, but this goes back to also having that equity person in place who has that lens. Next slide. The fourth part that I'm going to highlight in terms of a policy change or things that can happen that are really important around health equity and to advance health equity is this notion of fostering access. I'm only going to choose 2 things here that I could talk about, but there are so many more that I could have brought up, but I could have spent an entire time. I would like to highlight, I could spend an entire time that we have together on any one of these particular slides, and particularly an entire day on dismantling racism to advance health equity, but I digress. Fostering access. The 2 things I want to highlight here that are critically important is that we need to do a better job of really engaging and building trust in communities to understanding the importance of clinical trials. I am a person who has asthma and have had asthma for a very long time. And there's a lot of research that has been done that explains and shows that addressing asthma for Black and Latino kids particularly is not the medications that you use for the dominant population or the majority population doesn't always work or translate into populations of color. So we all know that this is very important, but what does it mean to foster access to clinical trials? This is where it's much more important to focus on, and I think it was Dr. Washington who made this point, focusing on trust and building trust and the importance of that in the context of being able to get individuals to wanting to be and understanding the need to be engaged and involved in clinical trials. This is where we cannot ignore the fundamental history and the importance of history in the context of how racism has really driven people away from being interested in participating in clinical trials. The other side of this is we also need to increase access to medical services, and COVID-19 has really highlighted the importance of increasing and making sure that we have the health insurance that is necessary for people. So I'm going to move on because I am noticing that I am really close to time. So if we could advance to 2 slides, please, and we'll go to the end. And I'll just say the following to wrap up. One of the things that's important is if you look at what I've offered today, there's always an opportunity for you to align the work you do on a daily basis to what your goals are already as it relates to health equity. But if you don't have goals, and this is the important part of why I added this on this, if you do not have goals around health equity that are specific and achievable and measurable, we can never achieve health equity, and we can never really pair that work around understanding how we're achieving health equity in the process of dismantling racism. So I will yield back the time, or I don't have time to yield. I will turn back the conversation to Mary, and thank you, and I look forward to the Q&A.
Thank you, Chiquisha. That was just terrific, learning about what's going on, the state level priorities, and there's nobody that left your presentation without knowing that we must confront and dismantle structural racism. So thank you so much. And now let me turn to Kara Jane.
Thank you, Mary, and good afternoon to all of you. Good morning for those of you on the West Coast. It is a pleasure to be here and to be joining this conversation with such a great group of folks. 10 minutes really is not a lot of time, so I am going to move pretty quickly through what I have to say so that we can get to the questions, which have been great in the chat feature. And just to start off, so Grantmakers in Health, we are a nonprofit educational organization that is dedicated to helping foundations and corporate giving programs improve the health of all people. We work with about 240 health foundations as well as philanthropy serving organizations in a variety of areas of health, including equity, access, older adults, behavioral health, and many others that have really come to the forefront during the course of the COVID pandemic. We work to sustain better health through philanthropy. And as we go back to sort of Mary's challenge to us as we were setting forth our conversation today, to really think about, what are the things that need to change for us to achieve health equity? To think big, and also that, one of the questions we asked is sort of, if we had an ideal world, what really does need to happen? You heard earlier from Dr. Natasha Washington that this disparities that have been brought to the forefront during COVID, and also from Michael, are not new. They really are not things that should be a surprise to us. In 1985, Dr. Margaret Heckler put out a report from HHS that was the first report to really document in a very systemic way the racial disparities that we have in our healthcare system. Since 2002, the Agency for Healthcare Research and Quality has been putting forth the National Healthcare Disparities and National Healthcare Quality Report that consistently show disparities in care, not just by race, ethnicity, but also by socioeconomic status. And we've had efforts all along the way, and even before that, to try and address the disparities that we've seen. But one of the things that I would say that we really need to do is to really get serious about addressing health disparities and to make health equity a priority. Often when we think about who's working on health equity and trying to address health disparities, it's kind of a small group of people, or maybe a single individual in an organization with limited resources that is trying to affect change. And when you think about the fact that that individual maybe, what is their ability to really affect change in a large organization, or even in a small organization or a large community, it really does kind of beg the question. So I would encourage us, and particularly if we're talking about the Leadership Consortium, is, sort of the ability to aim and foster cross-sector sharing and collaboration on a number of issues. I think elevating health equity as a priority, as it has already become, but understanding that it took us over 400 years to get to where we are. We're not going to undo these today or even next year, and that it needs to be a sustained priority for us to really achieve equity and close those gaps. So that would be one of the first things, is really to elevate that. One of the things that I will just say that each of these elements that I'm going to reflect on, you can find in the last GIH bulletin letter that I wrote on our GIH website, which is gih.org, and go through and talk about some of these practical steps that we can take to really achieve health equity. And again, making equity a priority, looking at our budgets. How does our equity work compare to other priority areas that we focus on? Is this something that is significantly smaller? Is it something that is comparable? Who do the individuals that are leading the work report to within those organizations and the communities? Again, is it on par with those of other areas or not? And when we have financially difficult times, what happens to our equity initiatives? Are they some of the first ones that we lose, or are they ones that we are able to sustain and focus on, given the importance of them? I think if we look at these questions and sort of if you see that there are discrepancies in the work that you're doing, maybe need to adjust to really ensure that equity is a priority. And if it's not, that is something also to have an honest conversation about, to think about, is it something that can be lifted up and embedded and focused in the rest of the work? The other role, and particularly as we're focusing on the work of the Leadership Consortium, is to strengthen the role of leadership. Leadership is so important across all sectors. In subtle and overt ways, leadership really does signal what's important. It can be things that are included in conversation, both in public spaces as well as in private closed-door communities and conversations. Things that are on our performance dashboard, what are we looking at and following, as well as what are we investing our professional and financial capital in. All of those things are important in terms of the leadership role and can signal how health equity could be something that can be sustained. And we need more leaders to think and engage in this space and to sustain that attention in this area. Oftentimes when we look at what leadership does, they sort of establish a program or set up an office and then maybe turn their attention to something else because they're getting pulled in many directions. But I think that we need that continued and sustained focus from leadership to help gather support for those who are working at other levels across organizations and in communities to really emphasize the importance and to help drive change. The third thing, and it goes back to our first session, the panel that we had on patient and person and family engagement, is to really think about how we are engaging and approaching communities and to make sure that we're doing that through humble inquiry. Working with communities can help to both identify what are the areas that we should be focusing on and not necessarily doing it from a top-down approach. What are the areas where we can improve in terms of working relationships, building bridges, as well as fostering collaboration. And Edgar Schein talks about humble inquiry, which is the fine art of drawing someone out, of asking questions to which you do not already know the answer, of building a relationship based on curiosity and interest in the other person. Applying that to a community-based approach as we're engaging with our communities, as I said, can help to foster collaboration, openness, trust, and lead to change. And one of the other things that we think about, and I saw one of the questions during the person and family engagement session, is how we are engaging those communities and thinking about how we reduce those barriers to increase participation. Oftentimes, we may have meetings that may not coincide with schedules for those in vulnerable communities. Transportation may be an issue, childcare may be an issue. Are we reimbursing them for their participation? I think how we are reducing those barriers to participation is important. One of the other things, though, is even within that, we talked about diversity or the lack thereof in many places. You may have one or two people who are focusing on these issues. Like a lot of us who do health equity, the phone is ringing off the hook and emails are coming through and we're getting a lot of requests and happy to fill those. But also, how are you engaging or maybe reimbursing those individuals for their time? Because this is part of their job, which is important, but there are also other things that they may be working on. So again, reducing those barriers, because with the limited number of people, they're getting probably probed multiple times with multiple requests. And so how can we foster that collaboration and support participation across all sectors to increase that engagement? But the other piece is, as you're engaging in communities and working with that humble inquiry, is to understand there's a lot of work that's probably already been done in that community. And it's important before you step into that space to take a moment to understand and evaluate the environment, figure out who the key players are, and to learn what's been done. Often we see that organizations or communities will come through with ideas, and I would just encourage us to, sort of reflect back on the statement in the disability community of nothing about us without us. So engaging with those communities to understand and include them in the process, to identify the areas that are most important to them, where they see those opportunities, to engage them in solution building so that they understand how those solutions may or may not work in that community, because there may be something we haven't thought of in terms of what will a barrier to engagement and participation. The fourth thing is to really reflect back on something that Keisha focused on, is data infrastructure. Data collection and analysis is not really sexy, except for among some of the more nerdier ones of us who get really excited about data. But without data, we cannot measure or monitor progress, and we really can't even identify where we have gaps. She reflected on the data needs that we have within COVID. But if you look across, again, the National Healthcare Disparities and Quality Report, or Health US from the CDC, or any of the number of other works on disparities and health equity, there's a lot we actually don't know. And we need to look at how we are prioritizing data collection so that we can do apples to apples comparison, because even within the states, we see a myriad of ways in which data on race and ethnicity is being captured. And whether or not, for example, it's being captured in the OMB, Office of Management and Budget data standards to have separation among Hispanic and race ethnicity. Thinking about other factors such as language or the social determinants of health, which we have talked about, but really making sure that we have that ability to collect, analyze, and report out on the findings that we have to be able to track disparities. We can't have it on a dashboard if we're not collecting it. And so I think it's one of the things that we really need to focus on. The fifth thing is really tackling the tough issues. Often when we develop strategic plans, we focus on the low-hanging fruit because it's something we can accomplish in 6 months, 9 months, or a year. But again, the disparities and inequities that we see in our system have taken years and centuries to build, and they're not things that we're going to cure in 6 or 9 months. So if you look at the foundations, if we really want to improve health disparities and achieve health equity, we have to tackle those systemic issues, things that our other speakers have talked about in terms of structural and systemic racism, but also looking at how we have inequities in our coverage, for example. Our healthcare system is largely built on a foundation of inequity where we have differences in coverage based on income, age, military service, or lack thereof, whether or not you're a member of a federally recognized tribe. All of those have different access coverage in terms of what's provided, payment rates to providers, creating incentives and disincentives for access and quality outcomes. And so tackling some of those tougher issues of how we do that. We've also talked about the social determinants of health. And one of the things that I would note is that this situation that we've talked about in terms of the pandemic and all of the other social justice issues have really brought to the forefront the role of race and racism in our health and healthcare system in our society. And what we had seen over the past few years as the social determinants of health had become something that was much more recognized in the clinical world. And I say the clinical world because sociologists, medical anthropologists, and others have talked about the social determinants of health for decades. And the World Health Organization had a commission on the social determinants of health going back to 2002. But as we have seen much more conversation focus on the social determinants of health, we've seen a crowding out of race and health and racism. And fewer folks who are looking at this with the thinking that if we address income inequalities, then we don't necessarily need to focus so much on race. And I would encourage us to continue to keep that, because even as we address social determinants of health and look at outcomes adjusted by the social determinants of health, we still see racial and ethnic disparities. They tend to shrink, but they do not necessarily disappear. And so it is important as we move forward to continue that focus and to keep that lens and to continue looking at disparities. The other piece that I would just say in terms of tackling those tough issues is it requires us to get outside of our comfort zone, to have some of those difficult conversations, to shine an internal light on where we may be not necessarily helping the situation, but where we may be contributing to some of the challenges that we have, and to reflecting on maldistribution of resources, which is also something that we can have seen for a long time and historically in our country. Next is really, making equity part of our standard operating procedures. I forgot who it was that said at the top of this, but as this is not a fad, I'm probably a little more cynical. I think that this is a window of opportunity where we are seeing a lot of attention that is focused on inequities and health equity, but I think it is a window of opportunity. And we have, if we look back historically at our issue and attention cycle, we have a lot of attention that's paid, then there's often a realization of what it takes to address these issues, and we start to see people fade in the support of them. And so during this time, I think it is critical that we think about how we get beachheads to really make sure that when that window closes and we move on to the next thing that arises and gathers our attention, we get at least a beachhead and make some progress so that when the window opens again, we're able to move forward and we're not left where we were or worse off. And so helping to make that part of our standard operating procedures is critically important. One of the ways in which we can do that is to think about and to borrow from something in the rural community that some countries have done, and that's called rural proofing. And it's a way in which we think about how, as we're developing programs and policies, they may impact service delivery, the healthcare workforce, health information system, as well as access to essential treatments and medicines, financing and budgeting, and governance and leadership. asking ourselves these questions on the front end, whether or not there may be a disproportional impact to try and address some of those, can help to mitigate some of the disparities that we may see and to help us develop more equitable policies and programs on the front end. So adapting that from an equity standpoint to center equity into the work that we're doing, but also embedding that focus on equity into our standard programs so that long after we've retired or moved on to our second career, if it is in baking or whatever that may be, the work continues. That is something that we want to make sure happens, and that it is not reliant on special resources to fund equity initiatives or other programs that may come and go as attention wanes and waxes. So that is another piece. The third is, the seventh one related to that is creating program and policy sustainability. Something we always talk about with our grantees and others of how they're creating sustainability so that when the grant ends, the program is able to continue. Thinking the same way in terms of our equity work, how is it sustainable over time? Maybe, with leadership changes, we may see differences in terms of issues and areas of attention and priority, but how does that work continue and have a budget that is not dependent on, fluctuations in time or so forth? And finally, to develop a robust pipeline. We talk about having diversity. We saw in the comment that was lifted up in the previous session by Desiree in terms of being the only person of color at the table. It's not an uncommon experience for many people who are in this space. And so we need a more robust pipeline. We need to support the development of programs to train individuals starting in high school and even before that to some extent, to make sure that we have a pool of applicants getting into college, graduating from college, who can go on to be able to serve as doctors, lawyers, teachers, community leaders, advocates, and health policy, reflecting even within the Leadership Consortium where there's an increase in diversity so that we're not asking one or two people to serve in 20, 30 different roles because we don't have a robust pool to choose from. Increasing the diversity at multiple tables increases the likelihood that we are able to have more policies and programs that are equitable and systems that are put in place that can bring up those issues and tackle those and understand them. So I would encourage us to really think about how we are focusing on that pipeline across our health and healthcare system to reflect the number of positions that we need, public health, government, leadership, and other spaces to really address health equity. And I think that if we can tackle some of these issues, then we really can move a lot closer towards achieving health equity. But again, as was said at the beginning, this is a marathon and not a sprint. And we need to make sure that we're supporting the development across all of these sectors to tackle those tough issues and achieve health equity. Thank you.
Thank you, Kara. It is time to get serious, and you have provided a thoughtful, provocative pathway to do so. And thanks to all of our panelists for really more than meeting the expectation of offering strategies, system and policy level strategies that move us toward long-term systemic change. So now let's turn for some brief reflections on panelist presentations. Let me start with Chris Kohler from the Milbank Memorial Fund.
Thank you, Dr. Naylor. This is Chris Kohler with the Milbank Memorial Fund. For those of you who aren't familiar with the fund, we're an operating foundation. Our mission is to improve population health by connecting leaders and decision makers with the best evidence and experience. We tend to focus most of that at the state level. So I'll be talking about state health policy, really because policy creates the ecosystem in which these initiatives operate. I want to thank the members of this panel for what were three really interesting presentations. I could just sort of end by saying amen to all of them, but you won't let me do that. So I'm going to do kind of a greatest hits of what stood out to me. First of all, from Dr. Wilkins, I want to highlight the sort of systemic response that Vanderbilt is trying to put in place. I do want to do a shout out for the National Academy of Medicine and compare this to work that I was privileged to be able to do on a committee on integrating social needs care into the delivery system. Social needs care is not the same, as Dr. Everett pointed out, as working on racial equity, but involves the same work at a systemic level. The 5 A's that the committee identified of becoming aware, of adjustment, of alignment, of assistance, of alignment, and advocacy. Think of those as 5 increasing concentric circles. I also want to highlight what Dr. Wilkins said about the community health needs assessment. From an advocacy standpoint, that's an unused tool that was created in the Affordable Care Act to hold institutions accountable for the work that they do, to the point where I think we should start talking about the investments that these large institutions are making with the reserves that they have. Dr. Everett went through a bunch of things about state health policy. I'm going to steal an emphasis that Dr. James said about Dr. Everett's presentation, and this emphasis on data. I would note that the importance of just normalizing this conversation by measuring consistently performance based on race and ethnicity. The inability of Medicaid agencies across the country to systematically collect and report on race ethnicity data is a clear example of where we could just simply operationalize this. There's a line from quality improvement. We improve what we measure. We have to measure this stuff on a regular basis, and Medicaid is a great starting place for that, as is Medicare, because the data is in one place. From Kara James, I know we were cautioned about the hero leader, but I want to emphasize what she said about leadership. In Dr. Everett's national map, I actually counted 6 states that were reporting testing rates by race and ethnicity. By my count, 4 of those 6 states have public health officers who are African American. I maintain that's not by accident that those are the states that are doing the measurement. That is specific efforts that leaders have put in place. They have to take that effort, and then they can be sustained into a regular pace, as Dr. James encouraged us. But leadership is really important, and we have to get a more diverse leadership if we're going to make this a priority. Finally, it's a little bit outside the realm of the National Academy of Medicine, but since we're talking about issues that are reinforced by science, I want to underscore the importance of the political process. We still have 13 states that have not expanded Medicaid. That is a result of political conflicts over competing values. If we are serious about racial equity, we have to engage the political process as well as the scientific process. The political process is where we work out competing values. If racial equity is a value that we hold dear, we have to win that in the court of public opinion. So thanks for a really stimulating set of conversations.
And thank you, Chris. Now move to Dr. Monica Burrell, who's Commissioner of the Massachusetts Department of Public Health.
Hello, thank you so much. Can you all hear me?
Yes.
I think I can, as Chris said, I think I could probably end by just saying, wow. I mean, those were 3 just unbelievable presentations. I spend a lot of time listening to and participating in groups talking about how to concretely address these systematic issues. And our 3 speakers just gave us such concrete, practical advice. Dr. Wilkins speaking specifically about disaggregating the data, really key for us all. And I think one of the key takeaways from this conversation we're having today, as well as setting up a task force and training, including, really importantly, we often talk about training individuals, but training at the C-suite and board level, really critical pieces. Dr. Everett very concretely giving state level policy changes that can be made. And I really would like to re-emphasize what you said on we must confront and dismantle structural racism to get to health equity. And Dr. James, again, your Enough is Enough framework with 8 different very concrete examples of issues that we can address. You know, I want to take that, and I am here in Massachusetts, the Commissioner of our Department of Public Health, and I want to end by giving a really quick example that when you were speaking, it really resonates with the work we're doing here. And so often I like to say, each one of us, wherever we're sitting, what is the lever that we can individually pull? And I hope that individuals listening to this will take all of the structure that you gave and the concrete examples and use that in whatever setting they're in, whether it's in a clinical setting, a systemic setting, a healthcare setting. So here in a public health setting at the Department of Public Health, since 2015, we have been working on our health equity plan, which is about health equity and health access for all individuals across Massachusetts. And as we started to do this, we took a precision public health view, if you will, and that was about looking at the existing data that we have and highlighting the social determinants of health, and then using our limited resources to target those areas where people need our programs and policies the most and looking for outcomes. As we began to do this work through an Office of Population Health, we actually found that unfortunately, almost every single one of the health inequities we were seeing were along racial lines. And so we then restructured and riveted the work that we were doing. A couple of our speakers broke this up to have a focus on racism and specifically racial health equity, and looking at institutional, individual, and structural racism in our work, both internally to the department and externally. And we began training of our senior leaders, as well as looking at all our work through a health equity lens, including how we gave out grants, how we did hiring, and how we did diversity training, et cetera. So really along the lines of what you were speaking about. And I must say, as we did this work and put the data forward, in many of our areas, we found that these inequities were along racial lines. For example, during the opioid crisis, we found the communities of color were one of the highest impacted, and then diverted some of our federal and other funding to really focus in on those areas and what they needed. And then now with the COVID-19 pandemic, which the first surge of it hit Massachusetts really hard, we have seen that COVID-19 is a pandemic and racism is a public health problem and pandemic, and the two are so entwined. And I'll have to get that reference from Dr. Everett, because in Massachusetts, we do also report on race and ethnicity related to COVID cases. So I'll have to get that corrected. But I want to say one thing about the data, just to add this as people are thinking. Initially, we weren't reporting on race and ethnicity related to our COVID-19 cases because, and so many of you have heard this before, we didn't have enough of the information. So as part of our public health emergency, we didn't stop there. And as part of our public health emergency, we put in an order under the commissioner, under my name, so that we mandated reporting. And we actually then were able to increase our numbers to almost 100% of deaths reported and doubling race and ethnicity reported in cases and hospitalization. And it helped us form a health equity advisory group and a task force, and are now going through systematically looking at the changes we need to make as we continue to confront COVID-19. So an example of really, to the principles you are all talking about, making the racial equity work a priority, a centerfold, and thinking about our policies and programming, because as many of you alluded to in your fantastic panel presentations, these policies and programs that were put in place that have caused this systemic structural racism for centuries now, they were put in place by people, and it'll take people just like all of us here to undo those policies and programming. Thank you very much, Mary.
Thank you, Monica. Now let's turn to Alan Richmond, Campus Community Partnerships for Health.
Hi, Mary. This is Anna. I believe that Al is no longer able to join us today. We can move to the person.
All right. We'll then move to Dr. Melissa Simon, Northwestern University Feinberg School of Medicine.
Hi, everybody. Good to be here. Thank you so much for the panel. It's so good to actually have some of my friends and my heroes on that panel. So again, enough is enough. I love that word. I say it all the time. Time to take this seriously. Took us 400 years to get to where we are. As Dr. James said, this is a marathon and sustained efforts are needed. Equity needs to be woven in the fabric of everything we do. And thus the structural barriers and opportunities need to be critically examined at every single level. And I love how leadership was highlighted and really trying to get towards that North Star of racial justice and rooted in being anti-racist in everything we do, not just eliminating racism. And the humility part is essential. Humble inquiry and communication with deep listening and deep learning, and being vulnerable and sitting in discomfort. I mean, for Black and Brown folks, we've been sitting in the discomfort for a very, very long time, and it is very uncomfortable, admittedly, when you haven't felt that before. And so really taking a moment to listen and learn, more than just a moment, because again, this is a marathon, and nothing about us without us is truly essential. We have to acknowledge all the dimensions of the work, and a lot of the great examples were given, moving away from race ethnicity as a biological variable in how we calculate GFR, or also in OB, I'm an obstetrician, the vaginal birth after cesarean section calculator has two numbers in it. One's for ethnicity, Latinx ethnicity, and African American race. So can we reconfigure that calculator, which a lot of people use across this country? There are many opportunities in terms of workforce and scientific development, in healthcare training as well, that like what constitutes professional school rankings. For example, medical school, does the MCAT score really have to be included in medical school rankings? So could we partner with US News and World Reports to try to rethink what actually is a ranking and why do we need one? Because those are more indicators that are structural, that are based on structural racism. Then also with respect to data collection, as it was said, all the left blank cases for COVID, it's remarkable across areas. Texas, about 50% are left blank for race ethnicity, and in Chicago, where I'm from, about 20 to 25% are left blank. And that really severely causes Black and Brown communities, especially we think Latinx communities and Native American communities, from further disinvestment, because that's how resources are allocated based on where the high levels of incidence are of COVID. So again, thinking about how we collect data is really important. And again, appropriate acknowledgement of who is doing this work, resource allocation. And then finally, I just want to close with words. Words matter. And so a lot of us use community engagement and community outreach in a lot of things we say or mention in health and healthcare delivery and in our institutions of higher learning. And that actually is a misnomer. I mean, engagement should be the absolute floor, the absolute minimum, because we have to think about how we really center communities in everything we do and weave in that racial justice framework and equity through everything we do. And the only way we can do that is actually centering communities, and the word engagement and outreach implies other. And if you continue to say other, then you're not really centering, and you're still making that separation. And so, for health and healthcare delivery, regardless if you're a nurse or a PA or pharmacist or a social worker or a physician, whatever, we are all in this on the same boat, and we have to center community. And so the way we use those words, community outreach and engagement, need to change. Thank you.
Thank you, Melissa. And now we turn to Dr. Regina Davis-Moss from the American Public Health Association.
Well, good afternoon, everyone, and thanks so much to the presenters and giving me the opportunity to respond. I just wanted to say hello on behalf of the American Public Health Association. We're a 150-year-old organization, largest in the world. And APHA is redoubling our efforts to advance racial equity. We have our own history in this work, and we invite you to partner with us. It's difficult when you come last because I don't have a lot to offer, other than to say, definitely would say amen to all the presentations. They were excellent. But I would lift up that I did really appreciate Dr. Wilkins' distinction between health equity and diversity and inclusion. A lot of times when we get into D&I work, it assumes, existing and potential employees are that are going to be targeted by the programs have to change to fit into a workplace culture. And it's not always the best at embracing identity and sustaining it. So I really like the notion of health equity being a true focus, because you can really get at this lack of resources and the opportunities that disadvantage certain groups. that was a great job of outlining how you can incorporate equity across an institution and as part of your standard operating procedures, Dr. James alluded to. With regard to Dr. Everett and Dr. James, I agree that you have to focus outside the healthcare system. But to be, taking a population approach is really challenging because it requires targeting the resources where they're most needed. And that really requires accepting the role of institutional racism and structural racism. And that is often where we butt up against a challenge, right? Because we have to, when you look at studies, I mean, we're split on whether or not we think it exists and who's to blame and how we tackle that. But we know that education and income are major drivers of health. We are still have a long ways to go in terms of the earning gap. I believe it's still been the same one has still been in existence since the late 60s, 70s. And so that's really where we have to act if we want to see change. I would echo that. I think we are in a unique time. I think there are reports that are now saying that this is the largest movement in history. And so, we're seeing people try to meet the moment, but I'm hopeful of that, but I really do agree that we have to commit to this and stay committed over time. And so, when we're seeing these people leaning in and try to reform, we also have to tackle those core issues, which goes back to racism. I would add that, APHA is tracking the number of cities, states, and counties that are naming racism as a determinant of health or a public health crisis or emergency. I think that those declarations are great. They're an important first step in the movement to advance these issues, but they have to be followed by the allocation of resources and they have to be followed with strategic action. If you're interested in learning more about that, we have those all cataloged on our website. And I just, as has already been said, COVID is underscoring what we already know. So the health inequities are driving the cases, the health disparities are driving the deaths, so the lack of usual source of care, uninsured. There are things that we can do now. We can advance Medicaid. We can open up the exchanges. So at the end of the day, though, we have to believe that healthcare is a human right. And once we get there, I feel like that we can make the change.
Thank you, Regina. And I know everyone on this call thanks Dr. Wilkins, Dr. Everett, and Dr. James, and all the respondents for really an outstanding session, helping us to understand how system changes, policy changes, and on a course, as all have described as a marathon, can lead us to, as was described, I think by Dr. Everett, as a state we don't know, but we need to get to. So now, remarkably, on time, turning it over to Michael for, I know, a number of really powerful questions to be addressed.
Thank you very much, Mary and Bill, and each of you who have spoken and who have made comments and who have inspired by virtue of the knowledge you've shared and the force of the issues with which you're dealing. We're now going to turn to questions from the audience, and we're pleased to have, well, actually, it's unfortunate that we have so many because we won't be able to answer them all directly, but we do have a lot. And it's a treat to be able to put some before you. Let's start with what we'll do is we'll actually divide this into two general categories, the categories around which the collaborative meeting has been organized, the patient engagement category, and then system changes that are necessary to achieve health equity. And so beginning with the patient engagement group, we have a question for Bev Johnson from Lynn Walton Haynes, who says initially, when I bring up equity in workplace, I'm often told, yes, it's a priority, but we don't have indicators to measure. So her question is, how do we move our organization beyond just reporting disparity by race, but to action? What are the top ways to include patients, communities, and measure effectiveness that organizations will acknowledge? That's quite an order for you, Bev. It, in essence, asked you to describe the central elements of the organization that you've been leading.
Sure. Thanks, Michael. And I think one beginning point would be to select a group of leaders in the organization and some of your patient and family and community partners and listen to this webinar. That would be a great way to begin to help understand both the issues, but also key strategies. I think to support senior leaders also in having honest conversations, and whether it's town halls with experienced facilitators, so they really have an opportunity to hear directly from the people that they serve in the community, so they can build those authentic collaboration. But they probably need to hold those kind of conversations with their staff as well. And I certainly agree with the impressive presentations of all the panelists today that we have to, in a much more concerted, direct way, deal with front and center the issues of racism. So to begin to create supportive ways to have those conversations, and then have leaders saying, okay, this is not just about talk. We have to start and develop true action plan and hold each other accountable.
Thank you, Bev.
Great question.
Actually, if I may, since it is a good question, asked Dr. Takesha Everett if she might offer some related reflections.
So I got so caught up in listening to Beverly speak. What was the question?
The question is, how basically can we move from reporting disparity by race, but to action, and essentially what are the ways in which that action can be undertaken in order to engage patients and communities, and how can we measure effectiveness in the results?
Yeah, so one of the things, I used to sit on a board of a healthcare system, and the key thing that I said is, you know, measuring the data is very important. Having the data is very important, and understanding the difference in the data is really significant. It's what you do with it that matters. And so it really becomes a conversation about how do you engage individuals both within the delivery of care, so those who are within the organization, as well as the people who are being served, and understanding why that gap exists. Asking that question 5 times, as the engineers do, why, until you kind of get to the root cause of that, and then be able to put things into action to change it. Many of the things we already know that are the problem, meaning, again, I've already talked today about racism being an issue. There are things that you can still do in the near term to really address the issues, or to address the gaps that you see. So I think one point that I would make to this is it's important to not only have the data, but really put into action plan, put into your plan, how do you make it actionable? And I think tying that actionable stage to that, to performance. So when I say performance, many of us have performance evaluations in the work that we do. How do you incorporate within that a real focus on making data actionable and actually moving into change in your performance evaluation process is very important. Those are the things that come top of mind.
Thank you very much, Takesha. The next question is from Sue Paulus of the National League of Cities. And it's for Dr. Washington. She says, having just spent a year with my 15-year-old at Children's National and Boston Children's, I'm struck by the differences in patient-centered care and person-centered care in just 2 institutions. There's really no place in most healthcare settings that allow for input unless you have a complaint and go through an ombudsman. a change in mindset is needed within hospital administration. How can patients, families, and those of us in healthcare administration or health services research help administrators to see the value in improving care and practices and invest in metrics, accountability structures to bring it to fruition?
Thank you. I hope you can hear me fairly clearly. One, I'll just say this, that the question has been asked year over year, how do we create the business case? The business case exists. There's tons of research that is out there that supports all of which has been shared by our panelists on today. And specifically when it comes to patient and family engagement, ATW Health Solutions, in collaboration with our CMS partners, Vizient, did some work to scientifically measure PFE and clinical quality outcomes. And so, you know, the notion that the work that we do in patient engagement, does it or does it not really impact outcomes? So there's research to support that work as well. So I think that what we have to do is two things, and it goes back to, you know, information I've heard on the call today. Number one, the commitment is really over the long haul, and trust is definitely a factor in developing relationships. Another person that asked a similar question in the chat box that I responded to a little bit earlier, and they were talking about the fact that we need to make certain that we're paying consumers or patient advocates to participate in these exercises so that we can actually get them. And what I have found is and please don't get me wrong, payment does incentivize across the board, so that is good. But what I have found in my own communities and working with disenfranchised communities and hospitals within is that when you take the time to educate the community about what it is that we're trying to do and how we're going about doing it, and you're able to substantiate that to Keisha's point about performance measurement, not just indicators, but performance measurement, it's a game changer. Because now you have a level of investment that goes beyond what we might be able to incentivize one with financially. So I would say that, number one, it's really about focusing on that trust factor and building the relationship. And then number two, it's really about, you know, making certain that we have an approach where we're taking the time to educate not just the leaders, but the community as well, so that we bridge that gap and bring everyone along the journey.
Thank you very much. This next question, I have to say, is not from a relative, but it's from Tricia McGinnis, so I have to ask it. And it says, it's a question for Dr. Wilkins, and it says, how did you engage community members and community-based organizations around your equitable COVID response? And to other reactors, have you seen any trends that suggest ways of engaging that tend to resonate most with non-majority populations? So the first is to Dr. Wilkins, and then if others from the commenters have comments, we'll turn to them.
Thank you for the question. It's obviously so important that we really hear from the communities that are most impacted or disproportionately impacted by this disease. We're fortunate that we have long-standing ties and relationships with many different communities in the Nashville area. So we're able to rely on them, leverage them, and work directly with community partners to actually convene those meetings. So our approach tends to be not that we need to set the table and invite people, but that we need to be able to be invited to tables and work with community organizations to talk about what would be the best approach to actually reaching those communities. So for example, we worked with El Mahaba, which is a center here in Nashville that really has longstanding ties to many immigrant and refugee communities. And we talked to them about the need for communicating with pregnant women who needed to come to the hospital regardless of whether or not we're in a pandemic, and how to actually get information to them in languages that their primary languages, and make sure they understood what was needed and necessary, And that center actually put together the platform, told us the time of day that they could host it, and made sure that that all of the information was translated and available with, you know, in Arabic, and had native speakers available. So that's typically our approach. And similarly, we did that with other communities, and we didn't just ask the questions or tell them things, but we wanted to hear from them. And that's so important if we're really talking about engagement, that there's this bi-directional communication, so that we are sharing information, but we're also hearing from them.
Thank you very much, Dr. Wilkins. I'm gonna, because we're short on time, I'm gonna move to the next question, and then we'll move to the system changes arena generally. The next question is from Susan DeVore at Premier Inc. Susan is also a very active member and co-chair of our Value Incentives and Systems Collaborative, a counterpart collaborative to this. And her question is to Dr. Washington, and it goes, I lead a healthcare supply chain and technology company, and I'm wondering whether I have health equity or disparities in our employee population, which spans the country. We all have the same employee benefit plans and access to those benefits, but I'm wondering whether we still have health disparities and how we would most effectively measure that. Dr. Washington?
Yeah, absolutely. So one of the first ways to begin to level up is take a look at compensation across your organization, across similar roles. Look at race, ethnicity, also gender, and see where those disparities exist. Most organizations that actually do go through the exercise find some pretty huge disparities in that. So warning, as you decide to use that approach. The other thing is looking at employee satisfaction. So another area to begin to use stratified data is employee satisfaction. So not only patient satisfaction, but also employee satisfaction, and really understanding what you're hearing differently, and understanding that in a deeper way, you know, by those stratified groups as well. And so I think that the other piece of it is, and it kind of goes back to the example that I talked about when I was working with Cook County Health System here in the Chicago area, is really to look at who you're serving, right? And when you look at who you're serving, now how does my staff, how does the concordance of the staff align with who we're serving? And so let me give you a little bit of an example. So generally speaking, when we do community engagement, and we engage across a multitude of race and ethnicities, meaning communities, and when doing that, it is important to have alignment or that concordance between that worker or the staff worker along with the community in which they're serving. There's research to support it, and I would suggest that you also take a look at those percentages of just, you know, who you have as it relates to staff and who you're serving. And now what are some of the strategies and some of the areas that you can begin to deploy to actually align some of those things? Because in order to really get to some of the solutions that my colleagues have talked about, it again is really going to require having the right voices at the table in order to nurture and to continue to challenge what the organization is doing in order to advance it forward. So I'd start with compensation, I'd look at satisfaction, and then of course I would look at that alignment across just staffing roles and the individuals that you have in place.
Thank you very much. Now moving to broader system changes. Here is a composite question from a number of individuals for Dr. James. And it runs as follows. How can we take advantage of this window of opportunity to make durable, structural, and systemic transformations that last on the long term? And how can we, in that respect, develop and sustain partnerships as allies, for example, with historically Black colleges and universities, and not exhaust Black, Indigenous, or other people of color that may be very limited in some rural areas? How do we avoid burnout or tokenism as we engage individuals in doing our work to combat health inequity?
Yeah, so thank you for that. There's a lot there. I think for those of us that are in the work and for those of you who are facing burnout, because there's a lot at this time, self-care is important. Find your support groups and make sure that you are taking care of yourself, because this is a marathon and we have a long road ahead of us. I think that one of the things that we've talked about a little bit in sort of my own circle is that I do feel like we do have a responsibility at this point in time to kind of push ourselves to help out and see what we can do, because there is so much engagement and opportunity in this space, and I want to make sure that if and when that window does begin to close, there won't be a question of could we have done more. I think that in terms of what we need to do looking forward, one of the things that we have talked about a little bit is developing a roadmap for an equitable recovery. So thinking sort of really strategically, what are those building blocks that we need to have? We've talked today about data. So how are we building data collection, analysis, and reporting into our systems to make sure that as we go forward, we don't have to ask questions about who got the vaccine. We don't have to ask questions about where are we in terms of providing the resources, where are those testing centers or other vaccine centers or however we're going to distribute that located. We don't have to ask questions about whether or not minority serving organizations or those small businesses are getting the resources needed to keep going. I think so. How do we start to really push through the data? We've already talked about some of the challenges at the state level in terms of data collection within the space of Medicaid and other public health infrastructure. There are conversations that are beginning in terms of the need to improve all of the public health infrastructure that we have seen and kind of not paid attention to over the past few years, making sure that equity is part of that conversation, and that as we are building this out, it is there centrally. I think the other thing I saw in the chat box is what is the role for our programs, Medicare and Medicaid. I think there is a strong role for those programs in terms of where there can be incentives as well as helping with some of the data collection. One of the areas we haven't talked about today, which I think is important, is how are we actually looking at building equity into our quality measurement. That is something that we look at a lot of quality measurement. We have standard measures that we do across any healthcare setting, nursing home, home health, dialysis, hospital. Where is equity in the measurement? Where are our measure developers in terms of looking at building those building blocks to be able to measure and monitor quality from an equitable standpoint, and that we are building into those programs. There's opportunity as we think about the supplemental benefits that are available in Medicare Advantage. Who's receiving those benefits? Which plans are offering those? Are they going to those who are most in need of those services, or do we see differences in what's happening there? The conversation that happened last year in terms of the AI and artificial intelligence and United Healthcare's care model that had unintended consequences. Again, those we sort of stumbled on that because that model wasn't actually built to include race, and it was only because those researchers were doing sort of race and ethnic disparities that we even found that. But I think that creating that roadmap, having concrete steps, collaborating, I think is really important. As we said, there are so many people that are pulling into this space at this point in time. There's a lot of energy. How do we focus that energy so that instead of having a million disparate projects, we really have people sort of pushing and rowing in the same direction to have an impact and maximizing that effect across the time. And then, as Chris mentioned in his remarks, policy, looking at those policies that are coming forth out of Congress, out of our state legislatures and others to really put those building blocks in to sustain those, because we, philanthropy, communities, academia, we all have a role to play. And the government also has a role in this space. So tackling this from every level of our socioeconomic model to ensure that we're building that in from the beginning. But again, for those who are in this for the long haul, know that you have a lot of support, and there are a lot of us in this space, and self-care so that you can preserve yourself for the long fight is really important.
Thank you very much, Dr. James. This next question is for Dr. Wilkins, and it's from Sabrina Lakhani, and it's about telehealth. How does the role of telehealth fit under the health equity umbrella? How can we structure this tool to reduce barriers to care and ensure that it does not exacerbate known disparities or allow a less robust quality of care for some populations?
So I think it's really interesting that what we've seen during the pandemic, where really the volume of telehealth visits increased exponentially. And for some groups of people, they couldn't be more thrilled at how great this was going and how many visits they could actually have. And for other groups, not so much. And similar to what we saw with the COVID-19 data, we saw the most striking disparities among people for whom English was not their primary language. And there were issues around getting interpreters actually to be part of the visit and accommodating them in that way. And certainly there are other issues not specific to people with limited English proficiency, but to racial and ethnic minorities, to people who live in rural communities, people who have limited resources that are around both the device, do they have devices that allow them to actually participate readily? Do they have actually, Wi-Fi access to high-speed internet? And so there's some access issues. There are also cultural issues. There are also differences in how homes are set up. And so, whether or not you have a place in your home that you can comfortably have a visit in private is something that we don't think a lot about from the standpoint of actually developing the technology and setting those things up. So there are issues that we actually have to address at all those levels. I think one area that we've not quite gotten a good understanding of is that, the issue around touch and proprioception and what people can feel and the dynamics of a personal interaction where you're putting your life in someone else's hand, that power imbalance for people who've been historically marginalized and minoritized and oppressed, that is a barrier that relates to trust and whether or not we actually want to participate in the visit that has nothing to do with access and device. So I think there are lots of things that we can learn during this process. We did take some specific steps during the pandemic to try and understand what barriers there were. Some of them were related to people not having an email address to link to a portal and preferring to actually use text messages and what systems could accommodate those. I think in the long run, use of telehealth could actually extend care. It could make care more accessible to some, but there's certainly sociocultural and access issues that we'll need to work through and be able to make sure that everybody has that opportunity to use it.
Thank you very much.
And if I could.
Yes, please.
Sorry, could I just add a couple other things to that? I think we've talked a lot about, the challenges and how that can help on the patient side. And we heard earlier about some of the broadband issues and the importance of making sure that people have that connection. I think we also need to think about the supports for the providers, particularly who may be serving some of the vulnerable populations. So there are some changes we still need to see that telehealth technically is only reimbursed in Medicare through rural settings, and so expanding that is a bit of something that we need some support from Congress to make permanent, and those changes that have been put in place during COVID. But also, sort of barriers across providers and state licensing and some of those other issues to break down some of those barriers to increase access across the way. And for those organizations that may have low operating margins, the ability to purchase some of the equipment and technology needed to support the expansion of telehealth are some of the other areas I think we also need to consider to make sure that those who are disproportionately serving vulnerable communities also are able to provide those services. And lastly, I would say is to make sure we're thinking about training and not assume that just because we're giving people iPads, even on the provider side, that they understand sort of how to use those and engage people in a way that is meaningful.
Thank you very much. We're going to go to one final question, but first I want to give a heads up to our last commenters, Chris Kohler, Monica Barrell, and the others, and indicate that we're going to come back and ask you each to give a maximum of 30 seconds on your key take-home observation from the days from the conversation that we've had over the last couple of hours that is actionable for the nation, and if you want to be more specific, for the National Academy of Medicine. But first, while you're thinking about that, let's go to the last question, which I believe was directed, well, we have a choice of many here, but the one that's flagged for me is for Dr. Everett, and it's from Linda Cast, and it says, health and healthcare are not equal to medicine and medical care. How do these efforts reach and include healthcare components beyond the triad of medicine, nursing, and pharmacy? How can we involve community in these efforts?
Thank you for the question. So the part of my presentation that I kind of shortchanged because of time was talking about the importance of community-based care and incorporating community health workers and other lay workers in the community in the process of advancing health. I think that generally speaking, the social determinants of health, or a lot of people are now saying social drivers of health or social influencers, either word you're using or phrase you're using, what a lot of that explains and helps us understand is that holistically, the process of getting to optimal health involves much more than just what's happening in the context of medical care. So involving and engaging the community, understanding that policy level change needs to involve not only what's happening within our healthcare system, but broadly our healthcare ecosystem, and looking at education, transportation, and housing policies, as well as what's happening within the on the medical side is very critical and important. I think the last piece that I would add to this is that when thinking, from my perspective, when I usually talk, I give this whole long discussion about how health is not just the medical piece of it, but it is the spiritual, the social, the ability to have, the whole well-being part of it is kind of all of those things together. And so I think that in order to move the dialogue forward, we need to concentrate, one, in the spaces that we work well in and have the highest elevation to do. So medical professionals need to be able to advance what's happening in the field of medicine as far as it can, but also in collaboration work with others to work where they are best suited to advance the conversation forward. I think that answers the question, but Michael, if I forgot any piece of it, I just call on you to call me out and ask me to respond to that piece.
I think it was a splendid answer. Thank you very much, Takesha. Let's now go to our lightning round, as I think the term of art is, and ask our commenters to give their 30 seconds most important take-home on culture and inclusiveness progress for the nation, or for the National Academy of Medicine as we move forward. Chris?
Oh, you let me go first twice. Thank you, Michael. I'm going to steal Kara's line, with apologies to all the other panelists, because you're all aware of it as well. But her line about humble inquiry sticks in my mind. I was having a side conversation, but as someone who's been the beneficiary of privilege myself, I think the framing of the approach as humble inquiry both encourages the persistence that we need, the curiosity that we need, and the respect that we need, and also gives us some agency regardless of where we are in the conversation. So I think that's something I can take home for myself, and I would hope everyone on the call could as well. So, and thanks to all the panelists again.
Thank you, Chris. I'll certainly take it to heart as well. Monica?
Yes, thank you so much. My takeaways, this is nothing new. We have to confront structural racism. There is a formula that so many of our speakers spoke about. The how is known, and the question is when, and I say now, and specific things that all of us can think about from wherever we sit, that we can start today. Increasing awareness, both our own and those people who work with us. Increasing training, there's a lot that NAM can do in that area. Data collection and data criteria, again, a lot to be done there. And then really thinking about the standard operating procedures and institutionalizing this week so it lives beyond this work, excuse me, so it lives beyond any one of us. Health equity, racial equity, it's about now. And thank you so much to all the speakers and for including me here.
Thank you, Monica. Alan?
He's not able to join.
Okay. Oh, yes, that's right. I'm sorry. Melissa?
Hi. I have nothing else to add. I think I summarized it in what I said, and I did emphasize the humble inquiry and moving away from the words engagement, because that should be the minimum amount we do to integrate community, and really trying to center community into everything we do with the goal, the North Star being racial justice. So that's what I think.
Thank you very much, Melissa. And Regina?
Sure. I would just add that the part of the privilege is not knowing, but once you know, you have to act. And that's what an ally does, is that you challenge the systems that you know about. And so, you know, we've taken that, if you take the public health approach, we've defined the problem, we've identified the risks and the protective factors, we've developed the strategies, and now we need the widespread adoption.
Thank you very much. Thanks to each and all for an incredibly rich and as I said earlier, inspiring set of observations and action opportunities. So we're going to turn now to our two co-chairs, Bill Novelli and Mary Naylor, for some wrap-up comments, and then I'll make just a couple of additional thank yous. So, Bill?
Thank you, Michael. You know, I think you did a good job at the very outset of stating the problem. And we've got some big problems in this country. We're facing big challenges. But, you know, what I took away from today was a deep sense of optimism. It's a really catalytic moment in American history and in terms of our health and our healthcare. And what we do now is critically important and I think a big opportunity. Kara James and Bev Johnson and some other people talked about leadership. And I think leadership is the key to what we're trying to do here. Leaders have courage, leaders do things. And one of the best things I ever learned about leadership was from Colin Powell. And what General Powell said was, you don't have to be the man or the woman at the top to be the leader. You can be the leader from the middle of the ranks. So I think the cross-cutting issues of today are optimism and the fact that we can all be leaders. Thank you.
Thank you, Bill. Mary?
So I want to let everyone on this call know that we began thinking about this webinar, this agenda for today in January and February, pre-COVID, because we at the National Academy of Medicine, the Leadership Consortium, and in this, particularly in this collaborative, believe that health equity is foundational. It's core to a culture of health that assures that every human can enjoy the high quality of life that they deserve. We could not have imagined what happened or what transpired and what is transpiring that made this seminar, webinar so important, so timely. And so let me just say that I feel very blessed today. I feel blessed that we have engaged the kind of stakeholders who are deeply committed to not just understanding the challenges, but who are activists, who are passionate activists, very engaged in showing us a path of solutions. I think we've been blessed to have moved this from a closed event to a public event because, as many have suggested, I think this could have meaning and value to students and clinicians and health system leaders. The conversation today is so central to understanding the opportunities with optimism, as Bill said. And I feel enormously blessed to be working with the staff at the National Academy of Medicine who pulled it all together. So while I join everyone, I join everyone in saying amen, 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 I also think that this represents a new beginning for us, perhaps as a collaborative, and it is an action collaborative. And we really want to hear from you about how we start on the path, on that journey that everybody has been talking about today, with all of the ideas sort of as a baseline to begin again, to get us to, as I will say again, a state we don't know, but where we absolutely need to be. So thank you all, and thank you to the audience, because you are as engaged as the rest of us, the presenters and respondents, in helping us to, and will be helping us to really move a very central agenda forward. So Michael?
Yes, thank you, Mary. And let me actually just pick up where you led us to and left off with, and that is the action component. We're called an action collaborative for a very specific reason, and that is we in the National Academy of Medicine feel obliged to facilitate action from all on the part of all of you, do everything we can to facilitate in that respect. We will be, what you can expect and follow up from us is a note with a link to the webinar and the briefing materials with background information on the topics that were discussed today and the presentation slides. And also included in that, I want to call this out in particular, a very short, easily accessible 2-page summary of the Action Collaborative's strategy framework. And I call out that because you get a sense of the kinds of things that the collaborative can do with you and on your behalf to facilitate progress. And so we're asking, as part of our ask to you, is that you get back to us on the kinds of activities that you feel we can help steward, that will do the most to achieve our collective vision of a nation and a world, for that matter, of health and healthcare, which is effective, efficient, equitable, and continuously learning. So please, as you scan the materials that are sent to you and as you reflect on the conversation today, please do be in touch. And Ayatollah Anisha has her email address right here on the slide. So it's just another indication of the staff's commitment, as Mary said, with Ayatollah and Anna and Fasika and actually a number of others who have been and are very much a part of the organization of the webinar today. So thanks to each of you, both for being with us, for what you're going to get back to us with in the way of comments and suggestions. Thanks to our wonderful co-chairs for their leadership, to each of the speakers and the commenters, and again, from my perspective, especially to the staff. We look forward to working with you, and we wish you Godspeed, be well, and be safe. Take care.
Thank you, Michael.
Thank you.